So our chairperson for this slide seminar, acute leukemia case presentation, is Dr. Nirmalya Roy Moulik. He is a professor pediatric oncopathology at TMC Mumbai. And our speaker is Dr. PG Subramaniam, professor in hematopathology lab at TMC. So students, you can identify yourself. Students?
Dr. Amit, can you please?
Amit is there?
Amit is not there.
Karan, you can start.
Yes, sir.
Please introduce yourself.
So myself, Karan Kumar Bora, second year postgraduate in Jorhat Metropolitan College from Assam, sir.
Good evening, sir. I'm Dr. Aditya, sir. I am from AFMC, second year residence.
Dr. Jayati.
Good evening, sir. I'm Dr. Jayati Gupta. I am a second year junior resident, Department of Pathology, Topiwala National Medical College and BYL Nair Charitable Hospital, Mumbai.
Dr. Archismita.
Good evening, ma'am. I'm Dr. Archismita Chakraborty, a second year PG resident from Fakhruddin Ali Ahmed Medical College and Hospital, Barpeta, Assam.
Dr. Devika.
Devika hasn't joined.
Dr. Susmita.
Good evening, ma'am and sir. I am Dr. Sushmita, third year pathology resident from Manukula Vinayaga Medical College, Puducherry.
Soumya.
Good evening, sir. I'm Dr. Soumya Netra from Chettinad Hospital and Research Institute, Chennai. Second year postgraduate.
Webinar hosts, our webinar hosts are on Dr. Anita Borges and Dr. Sumit Gujral and Dr. Ramaswamy. And I'm Dr. K. Moini Rao as a moderators. Few reminders. These are the few disclaimers. Upcoming talks by Dr. Fabiola Madrios and slide seminar by endocrine lesions. Let's start. Dr. Subramaniam, you can share the screen.
You have to stop sharing. Yeah. Moini, you have to stop sharing.
Is my screen visible?
Yes.
Okay. So we will try to cover acute leukemias. Like in 2 or 3 cases, the aim of this thing is just to introduce students to how an acute leukemia workup is done, and basically those areas of workup which are not readily available in most centers. So that is the thrust of this case presentation. So I will not be going through everything in morphology, but some of the stuff. So generally, this is a case 1. So the presentation is of a 22-year-old male who has fever, pallor giddiness of 7 days, has nasal bleeding of 10 days. Pallor is there on examination. Nasal bleed is also present, and very small lymph node, bilateral cervical lymph nodes were there on the clinical examination. So complete blood count was initially done outside, which was documented as high TLC, with hemoglobin is very low, 4.9, and platelets also low, 11,000. So this is the standard presentation of what would be called as a leukemia, or increase in whiteness of blood, which is the way it is coming as the name suggests. So the same thing was repeated at TMH. So here also there is a little reduction in count, because generally very high counts, they manage it outside before they are sent to a referral center to reduce the count so that the patient doesn't have serious problems during the shift to a referral center. So this is the peripheral smear. Jayati, can you just say what are the main features you're seeing in this focus or in this field which is there?
Yes, sir. So the RBCs They are hypochromic, microcytic. We can
I think this is a low power, so forget about the RBCs at this point in time. But main thing, what is a very low power?
The main thing is that the TLC is very high. So we're seeing a lot of white blood cells, and in that we're seeing a lot of lymphocytic looking cells.
Okay, so one of the things, at least in low power, I would want the residents to appreciate is, are the cells looking same or are they different? A normal smear will have cells of different size shapes. So this the cell uniformity of size shape is there. So that is the main thing, and there is an increase in number of white cell, as you have said, Jyoti. Good. So this is just a high power view. So Achusmita, can you just now elaborate on what is there? So here we can start looking at maybe RBCs, but I think for this case discussion, we'll forget about RBCs. We'll concentrate on the WBC. Yeah.
Sir, we can see two cells which look like lymphocytes with scan cytoplasm and coarse clumped chromatin, and another cell which is larger, which also has scanned cytoplasm, and we can also see nucleoli in this cell in the extreme right side, sir.
Okay. So the next question I would want say you are 6 of you there. So just give a poll as to what you feel. I would want all the 6 of you to attempt. Say the cell is a pointer visible.
Yes, sir.
Yeah. So what would you consider this cell as? If just if all of you agree that it is a lymphocyte,
Mature lymphocytes.
lymphoblast, lymphocyte or a lymphoblast?
Mature lymphocytes.
Lymphocytes.
Mature lymphocytes. Okay. So this is a very common confusion everybody has. Even I have it. Even the experts who are there, when they see the smear on an individual cell, there becomes a problem. So this is something which is there. So in this particular cell, it is really tricky to say, but we can hazard a guess of lymphoblast based on what is the overall picture in this case. So based on that, we can do that. But generally, what would you consider this cell as? The one here, it's in the lower left corner. All of you can join like the previous cell. Yeah.
Lymphocyte, mature.
So you think these both cells are the same? And what would you consider this large cell as?
That is a blast cell.
It's a blast. Okay, perfect. All of you are in agreement here. So I am also in agreement with you. So this is a blast, definitely. Now comes these two cells where there is a problem. So one of the ways I would go about, at least based on experience, this is not hard evidence, but experience. Generally, I would compare what is the size of the cell with the red cell. So this cell is, as compared to red cell, it is bigger or smaller?
Bigger.
Bigger.
So all of you are agreeing on bigger. So we have a consensus on this, on that. Regarding this cell, would you consider it bigger or smaller or equal size?
Almost same size.
Almost same size. So generally, if it is slightly bigger and there's a very little scanty cytoplasm, it is better to err towards a blast or a hematogone. If it is not a case of leukemia, this thing can be normal cell in children, especially as a hematogone. So this is one of the important confounding factors in morphology. So that is why morphologically we are, in many cases, we are not able to say definitively what is what. Okay. So next. Yeah. So you are having these with many blasts over here, a lot of changes. So what would you do next in a leukemia workup? This I would want Karan to take it up.
For workup, sir, we'll go for pus staining. Insert.
Okay, PA staining, yeah.
Which will show blood positivity.
But would PA stain be your first stain? Given a choice, imagine that you are in a lab where whatever you ask gets done. Then
So I'm
which
not
would
getting
be
the question, sir.
is PAS your first cytochemical stain in this case? In cytochemical stains, okay, there are multiple cytochemical stains. So which of the cytochemical stain you would want to do first in a workup of a leukemia? For any leukemia, because it's a most essential stain.
CD45.
MPO.
MPU.
MPO, myeloperoxidase is the most important thing. So MPO will have to be done. PAS stain is done, but PAS is not generally used in diagnostic criteria nowadays. So it has very limited role in diagnosis. But in settings where all the other features are not available, people still use PAS to a certain extent. So in that way, it is okay. So MPO is the most important stain to be done in this, because you have to know, though the blast look lymphoid, there are sometimes cases where they can be MPO positive, which will change your diagnosis from one end to another. So it's very important. So in this case, this is which stain? Sushmita, can take it up. Oh, no, Sushmita, are you there? Yeah. Okay. If Sushmita is not there, Soumya can take it up.
So MPU stain, sir.
This is a myeloperoxidase stain. Okay, fine. So why do you say it is an MPO stain? See, one of the things in MPO stain is, this is like, there are various methods of doing an MPO, but this is the most traditional method which has been there for a lot of years. So this is the most traditional of the one which uses benzidine, but nowadays people try to avoid using benzidine because it's carcinogenic, and it is used, people use other diaminobenzidine stains. So that is there. So this basically, this dark staining is what is, black staining is what is characteristic in terms of a benzidine, whereas your rest of the cells which are there. So this is your, these dark staining cells are your internal control, which could be a myeloid cells, and your blasts are
Not stained.
not stained. So in this case, our MPO interpretation would be positive or negative?
Negative.
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 Yeah. Okay. So the morphological impression at this end, what we can give based on this, what would be the morphological impression?
Lymphoblastic. Acute lymphoblastic.
Lymphoblast. Okay. If you are overconfident, you can call it as lymphoblast. I am an underconfident person, so I won't call it that. Yeah.
Acute leukemia. Acute
leukemia, myeloperoxidase
Negative.
or myeloperoxidase negative acute leukemia. I would leave it at that. If lymphoblast for me is a certain guess, because if the immunophenotype doesn't match it, then I will again end up in a position where I have said something wrong. But even if you say acute leukemia, myeloperoxidase negative, more likely to be a lymphoblastic leukemia is perfect for me. That is not a wrong thing to do. So myeloperoxidase negative acute leukemia. So now next let us go to the immunophenotype. So immunophenotyping, I will just go through the plots so that people just get an idea of what is there. So this is the first plot. So who is next? One of you can take, what does this plot show and what are we expected to do in this two plots?
Sir, this plot is showing FSC stands for forward scatter and SSC stands for side scatter. Forward scatter in flow cytometry, when the cells are passing through the laser light source, the forward deflection is equivalent to the size of the cell. So forward scatter would be showing the size of the cells, and side scatter is for the granularity of the cell. So in this plot, the red dots represent the population that we're interested in, and they will have
So yeah, so there are two things. So one of the things you're perfectly well, you have said forward scatter and side scatter. So forward scatter is telling you the size. The second thing it is telling you is normally you will have a lot of cells here. Neutrophils, which are high side scatter, have to be there. So this is actually mirroring what we saw in the morphology, that there is a uniform single large population of cells. So it is also comparable into that. So it is both are correlating. So that is one of the things. So you're having, so this red population, single population is there. So next, somebody can take this plot. What is this plot showing? So this is a standard orientation plot which we look for, which is CD45 versus side scatter. So what would be this population? So this population, which is CD45, we look at it like whatever is going upwards is having more CD45. Whatever is downwards is having no CD45. So those which are the brightest CD45 are our what we call as lymphocytes. So lymphocytes will have a brightest CD45. They will have the lowest side scatter also. This is the same side scatter which we saw in the previous. So the high side scatter cells, which are green in color, here are your granulocytes, and what comes over here is the monocytes. So this is the standard A4 cluster diagram which will come in any peripheral blood or bone marrow for a CD45 side scatter. So in this, the largest population, 92%, is here, which is at the CD45 dim position. So it is a CD45 dim blast. So next, who is next? Can Soumya take it up?
So in this scatter, so it's CD38 positive.
Yeah, it is CD38 positive. Yeah. So generally, we put two blocks like this. So normally CD38 positivity comes up to here. This population, which is bright CD38 positive, is where your normal plasma cells will fall. So this is a peripheral blood sample. So usually you don't expect plasma cells there. So this is completely blank here. Okay. So next is the, can Jayati take this up?
This is CD19 and CD10. So this is CD10 positive and CD19 positive.
Yeah.
19 and 10 is for lymphocytes, hematogones specifically, most commonly. And 19 is also a lymphocyte marker, especially B cell.
Okay. So 19 is a B cell marker. So 10 comes in lymphocytes. It comes in normal granulocytes also. In this case, if you look at the top portion, will tell you the gate, as compared to in this viability means all cells are there. So your grans are there. So if you go here, this portion is what is called as the CD45 progenitor gate. So what we have done in this plot is we have taken only those which are there in this CD45 progenitor gate. So that is the reason why in this plot no granulocytes are there. So you're not seeing the 10 positive granulocytes. Otherwise, granulocytes will come over here. So which is CD10 positive. So granulocytes also express CD10. So this is showing, so since we are having our predominant population is here and we are only interested in this, so that is why we are only looking at those population here, which is CD45 progenitor. So in any plot, this gate, the top one, which will tell you what is the gated portion of it. So this is the way. So in this, we have taken singlet gate. I have not shown, but generally we take singlet. Then this entire big gate. Somebody is asking for annotation, so I would suggest that please they don't ask, because it is annoying here to get it. So your this large gate which is coming here, that is your viability gate, and the smaller gate which is there is the MNC gate. So this large gate, viability gate, is what is put in this. So here you are having viability. So this is showing you all the viable cells. This is showing what is there. So this is again a 38 MNC gate. So we are again regating the mononuclear cells for that. In this, we have put a CD45 progenitor gate, and we have put a blast gate here and given it a color of red. So that is how the flow cytometry plots work. So next, Karan, can you take this?
Sure.
Yeah.
This plot is showing.
So again, here the gate is viability gate. Yeah, Karan, go ahead.
So this plot is showing the cells of interest are showing as CD34 positive. In this, sir, in the plot, sir.
Yeah.
And
CD34 negative.
negative, sir. Sorry, sir. Negative is showing in the plot.
Yeah. So plot is showing CD34. It is predominantly negative. A little bit of those red events are showing you CD34. And when you look at it, it is saying that CD34 positive cells are only 0.57% of the all the viable cells. So you are again having your granulocytes here, which are having high side scatter, and they don't usually show CD34. Okay. So this is a blast in which a small portion is CD34 and most of the predominant portion is CD34 negative. So this is again 19 versus side scatter. So as we had earlier seen, 19 is already positive in that. So 19 positive cells are there. Okay. So predominantly it is 19 is positive. Now you are having a 19 versus 34. So again, it is what it is again recapitulating what was earlier said. A small proportion is CD34 positive, 19 is positive here, and you have a small amount of blasts which are CD34 positive but 19 negative. So I'm getting a lot of noise. So is it from somebody?
I'll request the students, please make sure there is no noise around you, please. Thank you, Mani. Please go ahead.
Yeah. So this is a small amount of blasts here, which are showing, which is your normal myeloid blast. These are your leukemic blasts. This is your normal myeloid blast, which is a small amount which is there. So it doesn't mean that whenever a leukemia is there, it removes everything that is normal. A small proportion can survive. So this next, I think Soumya can take this up.
Sir, this CD20 positive, sir, with CD45 positive. The leukocyte common antigen is positive. CD20, the B cell marker, it is also positive.
Yeah, the only thing I would qualify the positivity, like CD20 is variably positive. It's not that everything is nicely positive for CD. You are having a whole spectrum from negative to positive. So this we call it as variable or heterogeneous positivity. So it can be heterogeneous, it can be called as variable positivity. And the 45, this is your lymphocytes, B cells, which are CD20 positive. And we have gated based on 19 positive cells, which is 19 positive, all the 19 positive. So you are having this CD20 positive, normal mature B cells, which are CD45 bright, because the 45 level is here, which is more than the level here. So this is actually 45 dim and CD20 is variable. Thank you, Soumya. Yeah. Next.
There is a doubt in the chat box. Can we still call them blasts if they are CD34 negative?
Yeah. So what we would talk about is not all blasts are CD34 positive. CD34 is positive in normal blasts. In normal blasts, CD34 is definitively positive. But once you talk about abnormal cells, then a whole range comes. So 34 can be negative in blasts. So if 34 is positive in the abnormal cell, you know definitively that they are blast. But if 34 is negative in the abnormal cells, you cannot say that they are not blasts. I hope I have answered the question.
Yes, sir.
So
Thank you.
yeah. So if 34 is negative, you cannot say that they are not blasts. So this is again 10 is moderate, 38 is moderate, as we have already seen. But here, this area is where we have marked this position where in our lab, normal hematogones will have a uniform 10 and 38. So they fall over here. So when we do an expression of various markers, we try to compare it with their corresponding normal. So in this 10 is nearly there as compared to normal, but it is slightly dimmer than normal. So that is one of the things which tells you that the cell is not normal, it is abnormal. So, and 38 is also slightly dimmer. So again, that is another abnormality. So this is the way we decide what is normal, what is abnormal, because we have to know where our normals fall, and based on that we say, especially if we are in an acute leukemia, it is not a problem. But if you are going to do a very rare event or a very small amount of tumor cells in a sample, these things become very important. So again, 10 is variable, 45 is there, you are having mature B cell. So this marking is the way a normal marrow should have. Normal marrow should not have any events in this area. Of the 19 positive cells, no 19 positive cells should fall outside this boundary which is marked. So this is your mature B cell, a little bit of this could be tumor or it could be normal, but it is somewhere close to the place where normal would be there, but it could still be tumor. But this area where it is completely different from normal is definitively a tumor. So this again answers the same question, like why we are calling it a blast. So we are calling it a blast based on 2-3 facts. One is the morphology. Morphology is showing you that there are hardly any normal cells. Second is this immunophenotypic abnormalities, which are telling you that they are not normal phenotype. So these two combinations we use when we try to say there is normal or abnormal cells. So again, 2010, we are again repeating what we have already seen. So this is 38. This is not generally required for MD level, but we use this marker. We do this marker at diagnosis because we also use this pattern for monitoring after treatment. So monitoring after treatment, we require to know what are the abnormal. So normally your CD19 positive cells should fall over here. They should not be positive for 304. So this 304 is a marker which is used as a leukemia associated immunophenotype. So when you hear a term called LAIP or leukemia associated immunophenotype, it means that those markers which are present in leukemia but which are not, or those marker features which are present or absent in leukemia, or those features of immunophenotype of leukemia which are different from normal. So that is a leukemia associated immunophenotype. So this is the 10 is variable. 86 is again slightly it goes out. So normally this is marked where the normal 1086 pattern should fall. So again, as you say, 86, a part of it is overexpressed, but otherwise it is very difficult. But the small portions you generally wouldn't. So this is a little different from immunohistochemistry in the sense that this is quantitative also. In immunohistochemistry, semi-quantitative. It is semi-quantitative at best. It cannot be quantitative. So, but semi-quantitative expression will be there. So this also gives us precise quantification of what is the antigen, what happens. So this is again 73 is variable. So it is falling within the normal, what would be a CD19 positive or a hematogone pattern. So this is showing you the normal pattern. It is falling within normal. So there is no abnormality when you look at 34 versus 73, which you can easily use for saying there is a leukemia. 25 is dim to is negative, it is normal. And 117, we expect it to be lymphoid. So lymphoid leukemias generally don't show 117, at least the B lymphoid ones. T lymphoid ones can still show 117. So 117 is negative. So 34 was in a very small proportion of cells, and 117 is negative. So 13 is a myeloid marker again. It is negative. So this I think this Sushmita, is she around? She can take it.
Yes, sir. I'm here,
Yeah.
sir.
Yeah.
So this is a plot against CD13 and HLA-DR. Here, HLA-DR is heterogeneous in the cell of interest, and CD13, a very small population of cells are CD13 positive.
Okay, very small proportion. For
Yes.
previously, those which were less than 20%, we never used to put in the report. But nowadays, in this case, we will ignore that very small. It will be less than 0.1%. We can relatively safely ignore it 99 out of 100 times. So we will say the 13 is negative, DR is moderate.
Positive.
DR is moderate.
Yes.
So what does so the DR is a marker which is there in almost all B cells. So in B lymphoblastic leukemias, DR will be a good mark. DR will be present in 99 out of 100 cases. It will be very rare case which will be DR negative. Whereas in T lymphoblastic lymphomas, DR can be negative. In AML, DR is generally positive, but DR is negative in a particular type of AML called acute promyelocytic leukemia. So in acute promyelocytic leukemia, DR is negative. In BALS, DR is almost always positive. So there is nothing like 100% positive, 100% negative in tumors, because they don't read textbooks. So you'll have a tumor which will always, an odd one which will always come out, which may not behave like what is written. But generally, these are the things which we will remember. So DR is there, and 34 is as in the previous. So again, 117 we have looked at. Now, next coming to, so Soumya, are you there? You can take it up.
Yes. So CD7 is positive and CD13 negative.
CD7 is what kind of positivity is there in CD7? Is all the cells positive?
Variable.
Yeah,
Variable.
so CD7, we will call it as variable or a heterogeneous positivity. And 13 is negative.
Negative.
So CD7 is a marker for what?
T cell.
T cell. So CD7 is a T cell marker. So we have come up to this much. So now we have a marker which is not usually there in textbooks. We call it as NG2. So this NG2 is positive in this. I'll come to this NG2 a little later. Okay. So 64117 is negative. DR is positive again. So all these other rest of the markers are all negative. So here you are having your normal T cells which are showing you CD3. So 7. So your normal T cells are here. Your 7 is variably positive, as we have seen before. So normal T cells will show you CD5 also. So this CD5 is a T cell marker. And 2 is positive in normal T cells. And there is a set of cells which are 2 positive, 5 negative. So these 2 positive, 5 negative cells are NK cells. So NK cells will not be expressing CD5 normally. So you will also have a small amount of NK cell in circulation. So 4 and 8 are double negative, so there is nothing here. Then you have 3 versus gamma delta. You'll have a small amount of normal gamma delta cells. Everybody has it. And predominant of the T cells will be alpha beta type, which is negative for gamma delta and which is positive for surface 3. So 1A is negative. MPO, Sai, can you take up the MPO CD3 here?
These cells are negative for both MPO and cytoplasmic CD3 markers.
Yeah. Now next thing also.
Sir, they are also negative for both MPO and CD79A, sir.
79A would you
Positive, sir. They're
positive for 79A. You are
Yes.
having a little bit of events here. These are your granulocytes, which will be MPO positive, and predominantly it is 79 alpha is positive here. So this is our final. So I'm just summarizing what we have seen. So blasts are CD45 dim, 19, 10, 38 and DR are moderate. 34 is in a subset, 20 and 7 are variable. 304 is predominantly positive, and 86 is overexpressed a little bit. 73 is dim to negative, it is positive 79 alpha. So Sai, what would be your impression if you put all the immunophenotype together?
I would go with the B cell.
B cell
ALL. B cell ALL, sir.
So
With aberrant, yes, sir.
Yeah. So my question would be, why do you call it as AL? Why is it not a B cell lymphoma? You have said B cell because 19 is there, 10 is there, 79 alpha is there. So in this, somebody has pointed out that 34 is negative.
Yes, sir.
So why would you still call it as a ALL and not a lymphoma?
So in lymphomas, usually they are CD45 positive, bright positive will be
correct.
Seen,
One, yeah.
And the CD34 is also noted, sir.
34 in a subset is noted. One, then they would be usually uniformly positive for 20.
Okay.
Because CD20 is an IHC marker for B-cell lymphomas generally. So CD20 uniform positivity will be there, a variable positivity is there. But the most important thing which you have said is CD45 is dim. So generally B-cell lymphomas are CD45 bright and never dim. So that intensity difference is very important. So that is why LCA, because we use intensity, LCA is very commonly used, not commonly used in IHC. It's not a favored marker for IHC, but we use LCA based on the gradation of expression. So based on the technique, there is a change in the marker and how we use it. So which are the pan B cell markers? So can you just tell us?
Yes, sir. Pan B cell would be, we'll have 19, 20, 10, 19, 20, 22, cytoplasmic 22. We'll grade them based on the intensity. If CD19 is bright, sir, then any one other marker, 79A and 22, if any of them are positive, then we take it as B cell lineage.
Yeah.
And if CD19 is dim, then we take two additional markers, that is CD79A and cytoplasmic CD22.
Okay. So good. So this is the way it is. So 19 is a pan B cell marker. 19 similar to 19 markers are not there in IHC. So IHC for see 19 is positive even in normal plasma cells. So it takes the entire B cell spectrum from precursor B cell, mature B cell up to plasma cell. 19 is positive, whereas in IHC the PAX5 is positive from precursor B cell to pre-plasma cell stage. In plasma cell, PAX5 is reduced and you get MUM1 there. So that this PAX5 MUM1 covers the B cell spectrum in IHC, whereas 19 covers the B cell spectrum in flow. So overall morphological immunophenotype, as you have said, is a B cell lymphoblastic leukemia. So is the diagnosis complete at this point of stage? So for acute leukemia, this is the beginning stage of the diagnosis. So diagnosis involves all the way reaching up to what is the molecular lesion, because there are a lot of things which are important for clinical management. So the next thing we will go into what is called as a ploidy analysis using a effect cycle violet dye. So this violet dye, effect cycle violet dye, is what is called as a stoichiometric dye for DNA. Stoichiometric means it binds in a exact proportion to the amount of DNA in the cell. So it has a ratio of binding with constant ratio of binding with the DNA in the cell. So its amount of dye bound is directly proportional to the amount of nucleic acid or DNA in the cell. So that is why it is called as stoichiometry. So that stoichiometric property we take advantage of, because the amount of DNA is proportional to the amount of dye bound in it, and the amount of dye will give you amount of fluorescent signal. So based on the amount of fluorescent signal, we can know what is the amount of DNA inside the cell. So that is what that's the way this ploidy analysis in flow works. So here we take there is a G1 phase and a G2 phase. So normally this is a normal lymphocyte. So we take the G1 phase median. So the X level median value comes here, mean value comes here. So this G1 mean of lymphocytes is 45.56 in this. G1 mean of blasts, similarly, if you see the proportion of S phase and G2 is higher in this is normal cells which are not growing much, normal lymphocytes. Look at the tumor, there is more S phase and G2 phase here in the tumor. So this tumor has, so we take the ratio of the tumor G1 peak, which is 46.61. We take a ratio which we call it as DNA index, blast to lymphocytes. So lymphocytes are our normal. The ratio of blast to normal gives us the DNA index. So it is 1.02. So 1 means they are basically deployed. Up to 1.16, 0.95 to 1.16 is deployed. Normal or deployed. So less than 0.9 is hypodeployed. More than 1.16 is hyperdeployed. Hyper means having more DNA. Hypo means having less DNA in cells. Because though the ploidy is based on chromosome numbers, the chromosome numbers are directly 1-to-1 proportional to the amount of DNA. So we are using a surrogate marker to find the ploidy. The gold standard is a metaphase based ploidy, which is there. So that is sometimes in ALL, the metaphase doesn't grow. And since we have got a peripheral blood sample, they generally require bone marrow for the cells to grow for cytogenetics. So many times in ALL, the cell growth fails and you cannot get a ploidy out of metaphase. So this is a very good way of getting the ploidy out of it. So this is we have developed it, and many centers are now taking up this method and using it. So this is just a review which is showing normal cell cycle. You have G1, S, G2 mitosis phase, and you have a G0 phase going from G1. So the G1 is in this peak. G2 is the smaller peak, which is 2 times. See, if this is at 100,000, this is at 200,000. So this is double the value of the G1 peak. And in between, you have variable cells. These are what is called as a synthetic phase. So in a synthetic phase, a cell is just duplicating its nuclear DNA. So the synthetic phase is the duplication phase. This G2 phase is the phase where the DNA has duplicated, then the cell will grow in size and then undergo mitosis and split the DNA into 2 halves and give it to the 2 daughter cells. So that is the way your normal cell cycle goes off. So this is, I'm just giving you some idea of how it is done. So this is like we put a gating marker along with the DNA dye. That's so that we are able to gate the normal as well as the abnormal cells. So this is your 45, we are using the lymphocytes, 45 bright lymphocytes, and which give the blue color, and the red color is your, so here we do the same and we get the ploidy here. So if you see, the peaks of both are overlapping. Similarly, for a hyperdeployed, you see here the ploidy is 0.72. So this is your lymphocyte peak, and your blast peak is left of the lymphocyte peak. Left means it is showing less DNA than the normal lymphocyte. So less DNA means less chromosome. That means it is hypodeployed. Similarly, for hyperdeploidy, again you have blast and lymphocytes and blast. So lymphocyte peak, blast peak, your ratio is 1.21. So when you merge, if you look at it, lymphocyte peak is here and your blast peak is to the right, G1 peak is to the right of the lymphocyte peak. That means the blasts are having at G1 phase more DNA than the lymphocyte. So since they are having more DNA, they are hyperdeployed. More DNA means more chromosome. That means hyperdeployed. So hyperdeployed is one category of BALL. So it is one of the diagnoses of BALL. So hyperdeployed can be done by this ploidy analysis. Other is through metaphase. Third way is to use FISH, where you will have triplication of 4, 10, 17, X, 21. So these chromosomes get triplicated. Whole chromosome triplication will be there. So that can also be measured by FISH. So that can also give you an idea of whether it is hyperdeployed. Hyperdeployed BALLs are very good prognostic BALL, one of the best prognostic BALLs, and they are very good BALLs. So it helps us to know how the patient is going to behave. So next we will come to FISH. So FISH, they put a set of markers, but the only marker which was informative was what is called as the KMT2A or MLL gene. So in this case, the FISH, they have done what is called as a break apart probe. Break apart probe means normally it should be yellow, like here. So the yellow means both the probes are on two halves and they come together at the same place, so they are yellow. The moment there is a split in the gene and one half goes to one spot and the other half goes to other spot, that means that this is abnormal. So this is the reverse of fusion probes. In fusion probes, this is normal and this yellow is abnormal. In break apart probes, the yellow is normal and these fusions are abnormal. So it is telling you that there is a break apart probe for MLL gene. So a chromosome banding is done and it is showing you a 411 translocation. So the 4 chromosome, this is the one which has undergone translocation. It has lost a chromosome here. That has added into the, this is the normal 11 chromosome. It has added into the normal 11 chromosomes and you're having this. So normally the chromosome numbering, just for people who are uninitiated, just broad. I am not a cytogeneticist, but just some broad principles. The earlier 1 to 5 are larger ones and later ones are smaller ones. So they are actually roughly ordered according to size. So here, this should be a larger chromosome, but you're having one which is smaller. And this should be a smaller chromosome and you're having one which is larger. So this is your 411 translocation for MLL. So now coming to this final diagnosis. So we take this final diagnosis as B lymphoblastic leukemia with KMT2A rearrangement. So just a little bit of theory here. So KMT2A or MLL gene has a lot of partners. So there are around 107 partners and aberrations into that. So this is a journal which gives you a lot of, so there are, so it has partner chromosomes in all other than 8 and 13 up till now. Maybe in future somebody will find one rare case which is having one of the partners in chromosome 8 or 13. 7 of the partners constitute more than 90% of the rearrangements. The MLL gene rearrangement can be seen in both ALL as well as in AML, but the 7 form the 90%. So the 7 are, one is this AF4, this is 411, then this MLL-T3, 911, then 1011, then 1119. So these are the ones which are generally the common ones which take care of. So an MLL, the break point happens towards the more later side. So this is the beginning of the protein. So in PTD, this earlier portion gets duplicated. So this is just to give you an idea of how, this is a normal MLL gene which has this much. So in a broken MLL gene, you only have this portion of the protein. This portion is missing and you have various partners coming and joining here. So this is the MLL translocation. So MLL is otherwise known as, the current name of the latest name is known as KMT2A. So it was initially this, since it was coming in AML as well as ALL, And in mixed lineage leukemias, it was given the name mixed lineage leukemia gene. So it came, this gene was initially isolated or understood based on the leukemia first. So it had an MLL. Now we know what this gene does. So it has a better name, which is called as KMT2A. K stands for lysine, which is the protein code for lysine. So lysine methyl transferase 2A. So what it does is, there are histone proteins around which the DNA is wound. So one of the histone is histone 3. The histone 3 has lysine at position 4 and position 36. So this MLL gene, what it does is it methylates the lysine on position 4 on a histone. That way it controls the epigenetics of the cell, or that epigenetic disturbance leads to the leukemia. So MLL is in that way. So this is the 5th edition classification. So you generally have these around 13 types of BALL which is there. So, and you have this NOS, which is the this 12th one, which is other defined abnormalities. This has another 7 in it. So it will be easily 20-21 types which are currently classified. So this comes in this KMT2A rearrangement. So KMT2A, this is just the changes between the 4th and the 5th. So there are around two new entities. One is this ETV6 RUNX1 like BALL. The other is the TCF3 HLF BALL. So in BALL with other genetic alterations is also a new entity which has other 7 genes which are associated with it. So there is a lot of genetics and molecular in this. So if you get a huge assay, unlikely at an MD level, but to get it, these things will be important. So generally, when we go for an ALL, we do a standard fusion probe FISH, whole chromosome probes, and break apart probes. So fusion probes, generally, we look for ETV6 RUNX1 or 1221, your BCR-ABL or 922, your TCF3 PBX1, which is 119, TCF3, HLF, this is 1719, IGH, IL3, whole chromosome probes for 4, 10, 17, 21. This is for detecting the hyperdiploid. And you do a RUNX1 gene. If you are having more than 5 RUNX1 copies, then it is important for IAMP21. So this is the way the FISH diagnosis goes. And you use break apart probes. So most commonly used one is this MLL gene one. These are used for a newer BCR-ABL like ALL. So in BCR-ABL like ALL, it can have ABL translocation, ABL1 translocation, which is the same ABL as in BCR-ABL1, ABL2 translocation, which is a related ABL. CRLF2 translocations constitute around 50% of the PH like ALL. So this can also be done using flow marker, where you look at CRLF2. The other JAK2 PDGFRB translocations are also part of PH like ALL. So Nirmalya, can you just comment on how we go about the treatment and what this means in this case?
Yes, sir. Am I audible?
Yeah.
Yeah. So, very nice talks. Made quite a things clearer to me. But yeah, ALL is the commonest blood cancer that we see in children. Of them, about about 3/4 or even more than that would be BALLs, as we have just discussed, and most of them are precursor BALLs. So ALL treatment has evolved over the last 50 years, but I'm going to tell you what exactly we do now. Overall, wherever you go in the world, it's a common backbone that is followed these days. It starts with very intensive chemotherapy given over hello?
We can't see you, Nirmalya. Can you switch on your video?
No, I will have to stop share. I will stop sharing. Yeah.
No, it's fine. I didn't switch on my video. It's okay. Yeah. So, can you see me now?
Yeah.
Yeah. So, what I was telling is that ALL is treated with very intensive chemotherapy and in separate blocks. So, currently, we treat a newly diagnosed patient with multi-agent chemotherapy, and the first block is called induction. By induction, we mean, this is the phase where we achieve maximum cytoreduction. For example, a patient who comes with a 90% blast or blast close to 100% sometimes, we would cytoreduce this patient maximally during induction to reach a submicroscopic level of disease. So much so that, as most of you would be familiar with the term called MRD, so much so that many of the patients will clear their MRDs by the first cycle of chemotherapy, which is called induction. But if you stop after that, the disease is bound to come back. So what we do is to consolidate this treatment with further cycles of chemotherapy. And these cycles are sequentially called as consolidation. Then we use another cycle called interim maintenance, followed by another induction type treatment, which is called delayed intensification. So this comprises of the initial intensive blocks of treatment that is used for ALL therapy. However, it has been observed over the last many decades that ALL treatment has evolved over, that if you stop with the intensive chemotherapy, the chances of the disease getting cured are not that great. Only about 15 to 20% of the patients would get cured if you stop your treatment after the end of intensive chemotherapy. So what comes next? So based on the experience for so many years, we have now found that this ALL-like treatment also should include a protracted course of low-dose chemotherapy to keep the disease under control. This protracted course of chemotherapy is called as maintenance chemotherapy. So most of the patients, all the patients with ALL in the current era would get a very intensive phase of chemotherapy starting from induction to delayed intensification, followed by a lower dose oral chemotherapy that will continue for at least 2 years. So making the treatment duration going up to 2.5 to 3 years in some instances. So starting with induction, consolidation, interim maintenance, then reinduction or delayed intensification, we don't stop. We treat these patients for another 2 years, at least another 2 years, in order to prevent the disease from coming back. So this is the importance of giving a protracted treatment in ALL. It has been seen that the submicroscopic or the below MRD clones that persist in the patients, they are adequately tackled when you use this low dose chemotherapy for 2 years, and it is very much essential to treat it like that. No one would dare to not give maintenance chemotherapy in patients with ALL. And pediatric ALL is the poster boy of pediatric oncology, or for that matter, medical oncology as well, because in the 1950s and 60s, where we would only be able to treat and cure about 10% of all pediatric ALL patients. But if you see the latest data, the outcome has actually gone through the roof. It's more than 95% in the best of the settings. So, it's really a remarkable achievement that has been attained. And as I told you, this is as a result of the last 50 years of clinical trials. And here we are now, where we treat with intensive chemotherapy, followed by a protracted low dose maintenance for these patients. Anything else I want me to tell?
No, I think that's fine. So I will again move forward. Thank you, Nirmalya, for giving us an overview, because many of the pathologists know it is an acute leukemia, but after that, what you do, we are very foggy. So it is important for us to understand what it is done.
Yes, I just one more thing I want to mention here, sir. As we have diagnosed a case of ALL, it's also important to monitor the treatment response. These days, treatment is adopted based on the baseline characteristics as well as the information that you get from cytogenetics, as Dr. Mani has just shown, some molecular markers as well. And of course, what is also important, and probably the most important factor, is to see how these patients respond to chemotherapy. And that response is assessed by MRD. And I'm sure you people are familiar with MRD, and there are sophisticated techniques of using multiple colors in the flow cytometry to arrive at an MRD to better stratify these patients. So MRD is another important thing that has changed the practice of treating ALL. Thank you.
Nirmalya, only one question from one of the audience. They all want to know, like, when all do you do your MRD?
So it all depends on the protocol that you are following. But most of the protocols would be doing MRD after the end of induction, which is about around day 35 from the start of treatment, and repeat it only if necessary after consolidation. But then it's very much protocol specific. Some of the groups have started doing MRD quite early on in treatment. For example, within a week or 2 weeks of starting treatment. And they say the earlier the disease clears, the better the prognosis. So, I mean, in the process of doing early MRDs, you can probably pick up a subgroup of patients who are going to do very well. So for all practical purposes, MRD is to be done after the first cycle of chemotherapy or sometimes earlier. And if the patient continues to be MRD positive, we keep on repeating the MRD after each cycle of chemotherapy and see when the patient clears their MRD. So there are multiple time points that I mean you can do the MRD on, but of course the most important is probably after the first cycle of chemotherapy.
Thank you, Dr. Nirmalya. So I think I will move on to the next case.
Yes, please. Thank you.
Yeah. So next case is case number 2. So again, a 16-year-old male, generalized weakness, abdominal discomfort. CBC is again showing anemia, high counts. Platelets is relatively high as compared to the previous case. And peripheral blood blasts were 34%. There was pallor, but no lymphadenopathy. But there was liver and spleen was palpable in the patient. So this is the again similar peripheral blood picture, which is showing you increase in blasts, and you have these blasts which are again like previously, but looking more or less uniform, as we have seen here with few large blasts and small blasts. So the small blasts generally are more characteristic of an ALL. So these kind of small blasts are characteristic of an ALL, both B as well as T. So they are one way of understanding whether, so basically when you say small, you compare with your red cells. So if they are very close to red cell, they are small blasts. So small blast is very characteristic of ALL. So this is one of the ways you look at and pick up ALL. So this is again showing you the blast. So in ALL you can have blasts which show nucleoli like this one and which don't show nucleoli. So a mix of both nucleolated and non-nucleolated blasts is again another characteristic of an ALL. So these two are, whereas in AML, most of the blasts will be having nucleoli. So they will have a presence of nucleoli. So absence of nucleoli is those kind of, in traditional way, they were called as L1 blasts. This I'm talking about is the original 1976 classification of acute leukemia, the first attempt at classifying acute leukemias by John Bennett in 1976. So in that it was called as L1 blasts. So in this also the MPO is negative as before. So immunophenotype. So it is. I think I will do the interpretation in this most of it. 45 is dim to negative in this, and you are having similar forward side scatter as the previous case because it's predominantly blast and there are hardly very less other kind of cells. So in this, Sai, can you take the interpretation for this?
These blasts are 19 positive, sir, heterogeneously positive, and they're also positive for CD10.
Your normal B cells are here. I know it is probably, unless you are very close to the screen, those dots are not visible. There are very little dots here. So normal B cell is here. So how would you consider your 19 now?
Then negative, sir.
So would you call it negative, all negative? See, this is your double negative. So your negative line, if I'm going to put, it will be somewhere around here. So it is like dim to negative 19. So 19 is dim to negative.
Dim to negative,
and,
yes, sir.
And 10 is moderate. So 19 is dim to negative, 10 is moderate. So in this case, we are not unsure of blast because everything is CD34 positive. And you are having 20 is like dim to negative 20. So again, dim to negative 20. So you are having 38 is again dim to negative. So your hematogone has to be here. So in this also, this is also not showing normal B cell phenotype. 10 is intensity is like near normal, but the 38 intensity is very much reduced. So CD38 is the very commonest leukemia associated phenotype for a BAL. So 38 becomes very important antigen for us to say something is BAL. So earlier there was a confusion BAL or not. So absence of 38 is also one of the important LAIPs or leukemia associated phenotype. Underexpression or absence of CD38 is a leukemia associated phenotype. The reason is normal hematochrome, the 38 always falls here. They never go down or not. But mature B cells, the 38 will be here. 38 will be negative in mature B cells. But in hematogones, 38 will always be here. Hematogones are maturing B cells. That is from blast to mature B cell, those region is taken up by hematogone. Our bone marrow is the site of production of our B cells in our body. B cells are produced in the bone marrow. So they are the hematogones. They, after they become mature B cell, they go to various lymphoid organs from the various parts of the body and populate the lymphoid organs. Some of them mature further into circulating lymphocytes or into the lymph node. So all of these is, but their source of origin of the B cells in the body is coming from the bone marrow. So here we are not having everything 34, 304 positive, 304 is heterogeneous. You are having 3473. So normally this is the way 3473 is. So in the 73 is also becomes a leukemia associated phenotype because it is not falling in normal region. So in this, if any normal cell is 34 positive, it should not show 73. In this, it is 34 is positive, but it is showing 73. So that is the way the abnormality we describe based on the phenotype. So this is abnormal. Again, 25 is partially positive in this. So, and DR is variable. There is like from dim onwards all the way up to the top. 38 is negative. So DR is variable again. 117 is negative. 13 is negative. 7 and is also negative in this. So there are other things are not there. So this is your 756 positive NK cell. You are having a little bit of 15 in the blast population. This 11B, 15 bright 11B going, this is your normal maturing granulocytes. So immature granulocytes are here. As they mature, they go here. So this is your maturation pathway. So this is a maturing. So your blasts will be here. They acquire 15 and then become the 11B positive granulocytes. So 117 is negative. NG2 is negative in this. So previously, I had come in the previous case, NG2 was positive. So NG2 is a surrogate marker or a flow marker, which will tell you that there is a good chance that this patient is going to be positive for MLL translocation. So NG2 is a marker for MLL translocation. So this NG2 positivity will tell whether one is MLL positive, very likely to be MLL positive or not. It is not hard and fast, but it's a very good marker, especially significant proportion of blasts are NG2 positive. They are a predictor of MLLG. So your 33 is dim to negative here or variable. Your 64 is negative, 117 is negative, DR is a variable here. So 11C14 is negative. So you are having 5, 7 is negative. So this, as we have said, everything, all the T cell markers, 2, 5, 7, 4, 8, everything is negative. So 334 is also is nicely moderately positive. So your so anti-MPO is, so now next Jayati, can you just interpret this MPO versus cytoplasmic CD3? The reason it is written as cytoplasmic CD3 is that this is not CD3 on the surface of a cell like in a normal T cell. This is both this says if there is surface also it will show you positive, but if it is inside the cell also it will show you positive. So that is why it is called as a cytoplasmic CD3. So this is done during processing which we do. So Jayati, can you just interpret this plot?
Sir, in this plot, it shows MPO negative and cytoplasmic CD3 negative as well.
Cytoplasmic CD3. Very good. Now, when we go into the next plot, Jayati.
In this, sir, the gate is all the viable cells, and in this, cytoplasmic CD79A is positive, and 10 CD10 is also positive.
Positive, correct. So next, in this plot, Jayati.
Sir, in this, we've taken 38 positive cells, and in this, CD22 is variably positive.
Yeah.
Dim to positive.
See this portion, which is 19 and 22, is your mature B cell.
Mature B cell, yes, sir. And 19 is negative.
So this is the mature B cell. So you are having 22, which is dimmer than it is. It is positive for 22 because negative for 22 is here. It's positive for 22, but it is dimmer than the mature. So here also it is positive for 19, but it is dimmer than mature. Like we had said in the first plot, that 19 is dim to negative. Okay. So this all of you can attempt. So what would you consider this as?
So this is also B cell ALL.
Okay. So
with aberrant expression of myeloid markers with 13 is not 33.
1533, correct. Yeah. So this is 10 is bright, 34 moderate. If, for example, you didn't do 22, so your lab didn't have 22, what would you have reported this as? Suppose you don't know 22, your lab didn't have CD22. Any of you can come in? Like, because in the previous case, we didn't put 22. Whereas in this case, we have put 22.
Only acute leukemia with blast showing both.
If 22 was not there, would it meet the criteria for a BA?
Yes, sir. Still, because our MPO is negative here, so we are ruling
MPO
out.
is negative. Yeah, but 19 is dim to negative, so 19 is not bright.
But in addition, if when 19 is dim to bright or dim to negative, okay. Then we have 79 and 22 in support, sir. If 22 is
79,
not there.
79. So how many markers do you need for support? 79 alone will do?
No, sir. 2 are required.
2 are required. So if 22 is not done in this, we will not get the confirmation of a B phenotype. Okay. So when there is 19 dim, you have to do both 79 alpha as well as 22, because then only it becomes a B confirmatory. Both are there. Like for example, in this 22 is dim. So otherwise it will become ambiguous lineage. So I'm just telling you that for the criteria basis, what all markers, how this marker usage is there. So they have given a complicated criteria for many times the residents, they feel why this much complexity is there. So the cases come in this way. So you have to put both, so to get into the level of whether it is B or not.
Sir, I have a small doubt, sir.
Yeah.
So in the criteria, it says like if weak CD19 is there, then strong expression of 2 markers, that is 79 alpha and 22 must be there. But in this case, it's not like that. So still can we still confirm it as we?
No, it doesn't say strong expression. You have to have 2 markers. I'm not very sure, because I think I have the I think the subsequent slides have the criteria there. So we'll just go at it.
Sure.
Okay. So the morphological and immunophenotypic features are of B-cell lymphoblastic leukemia. So this is where the criteria comes. So either 79 alpha, 22 or 10. So in this 10 is strongly expressed and 79 alpha is how is 79 alpha expressed?
Moderate.
It's moderate. So both are strongly expressed. Okay. So in this, the 10 and 79 alpha, so 22 may not be essential, that you have said is correct. But generally, I would favor having 3 of them together. Okay. But on the other hand, if you had only 22 and you didn't have 79 alpha, then this case becomes more weaker of that. Okay. So this is the one of the things which this is very important set of criteria for the lineage assignment. So everybody has to be familiar with this.
So one doubt related to this case, if with the lab did not have CD22, how to report this then?
Not CD22, 79 alpha is not there. In this sense, 79 alpha has come strongly, 79 alpha and 10 are important. So if you didn't have 79 alpha and you had 22 and 22 is dim, then this criteria is not met. You have only 1 strong, you have 10 strong, your 22 is weak.
Okay, sir.
So that is why this 3 markers becomes essential for subtyping of B in cases where it is difficult. The other thing which they have written in this, previously they never used to write this zeta chain. So they have written this in this because we always think when we say CD3, everybody says CD3. CD3 actually has 4 types. 4 chains. Antibodies are against 4 chains. So when a textbook blindly says CD3, it always means CD3 epsilon. So that is something which you have to understand, that it is CD3 epsilon, not CD3 zeta. So CD3 epsilon, if you put CD3 zeta, CD3 epsilon is not there in NK cells. Where on cytoplasmic stain, CD3 epsilon is not there in NK cells, but CD3 zeta is there in NK cells. So in NK cells, if you put the wrong type of CD3, you would end up having interpretative problems. So CD3 epsilon is what is generally considered when you say CD3. It is understood that it is epsilon when you just say CD3. If it is a non-epsilon, they will usually write it as CD3 zeta. So that is where it is written. So that is one of the things. So this time I think there are labs which have got confused, so they have put this into the WHO this time as clearly. So ploidy analysis revealed diploidy in this case. So BCR-ABL fluorescence. So here this is a fusion probe where normal is this separate, and this yellow dot which is coming here, this is your fluorescence positive signal. So you have normal here, this cell is showing you normal, and this is showing you fusion. So 1 yellow, 1 red, 1 green. So this is the BCR-ABL which was positive in this case. So other thing is important is that whenever we get CD34 such homogeneous in a BALL expressing the CD25, it is very high chance that the patient will have a BCR-ABL. So that is also one of the ways of looking at it, because the immunophenotype also suggests what can be possible genetic lesion in this. So this is again has come out as positive in BCR-ABL. So this is a cytogenetics with BCR-ABL positive in 922. So you have this 22. 22 is a small chromosome. The 22 becomes even smaller chromosome. So this is what is called as your Philadelphia. So you have your 922 chromosome here, which is coming. So just knowing it is BCR-ABL won't do, because you require some things for monitoring of BCR-ABL. Generally, it is done using molecular monitoring. So you have to know what kind of transcript is there. So we do a multiplex PCR for various transcript types of BCR-ABL. So this is showing that, so this is showing that this is the patient's case. So there is a band here. This band matches the 481 base pair, which is of E1A2. So there are various primers. So based on the sizing, we will know which transcript type it is. So E13A2 is here, E14A2 is here, E1A2 is here. So various BCR-ABL types are there, which I think we have covered in the CML talk. So this is a E1A2 transcript type, or in terms of protein, it is P190. This E13A2 and E14A2 are P210 type transcripts, and this is the P190. So this is the commonest P190 associated ALL transcript in this case. So it is a E1A2. So this is important because post-therapy monitoring in this case will be done by both by a combination of flow as well as by molecular using this BCR-ABL qPCR. So in this, there was induction was done, post-induction monitoring. So we have got this BCR-ABL. This patient in this had a reasonably good response. So his normalized copy number became very low, 0.7. So post-induction monitoring is there. So Nirmalya, you want to give any comment on this case, BCR-ABL ALL?
So yeah, I mean, just one thing, BCR-ABL positive ALLs are also treated like ALL only. Very similar treatment, but they are known to be more chemo resistant. So they end up getting more intensive chemo in the current protocols. But what is important is that because of availability of TKIs, which are I mean, targeted agents against this BCR-ABL1 fusion protein. So TKIs have revolutionized the management of all pH positive leukemias, for that matter, CML or ALL, and even AML now. So in addition to the chemotherapy, a tyrosine kinase inhibitor is added, and treatment continues for the same duration, 2.5 to 3 years. And after 3 years, for patients who respond well, we are able to stop chemotherapy as well as TKIs in the setting of pH positive ALL. And more patients than the others, I mean, than the non-pH positive patients would need bone marrow transplant also because of lack of adequate response in the setting of pH positive ALL, which reflects the, I mean, innate chemotherapy resistance of these leukemic clones. Despite the use of TKIs, I mean, a significant proportion of these patients would go on to need transplant. So that's it, sir.
Okay. So, so Dr. Gujral, do we continue to case 3?
Of course, Mani, why not?
Okay.
You can quickly go through. No, it's still 8:23. You can go through it.
Okay. So this is again 12-year-old boy. This is a little more complicated, so I won't be showing all details. So, but just to give an idea. So this is a known case of BLL. It was a known case.
Can you share your screen?
Oh, sorry. Okay. So screen is visible?
Yes, sir.
Is the screen visible?
Yes, sir.
Yes, sir. So it's a 12-year-old boy who is a known patient of BALL, high risk, on treatment for 4 months, had completed induction and third maintenance, and he had a post-induction MRD was negative, so he was doing well. And suddenly after this M3, his counts were not recovering. He was having hemoglobin 11, TLC is very low, platelet is very low. So clinically they started suspecting relapse. So in addition to that, the patient in peripheral blood had monocytosis. So they were seeing monocytes So they started doing a marrow. So marrow was full of blasts which were looking more like monocytic blasts. So they were MPO negative. So this is the flow. We will start with flow here. We'll skip the molecular for brevity. So you have 45 is dim here. You have 1934 is negative. So 38 is negative. So if it was BALL, 19 should have been positive. So it is completely negative here. And 38 is moderate. So 34 is also negative. You are having again 38. 123 is dim. You have 86, which is positive in most of the cells. Your DR, which is moderate. Your 756 negative. 117 is negative. You are having 11B is positive in this case, and 15 is also nicely positive. So 11B, 15 is nicely positive. 45 is dim. Side scatter is low. You have DR positive. 13 is nearly negative, a little bit of it. 33 is nicely moderately positive. Your 64 is nicely moderately positive. You have DR is moderate. 14, a little bit of 14 is there. This is the way normal monocyte maturation matures. So it is not like normal monocyte maturation, a little bit towards monocyte kind of a lineage is there here. I think, yeah, here. So this is like it is a little bit. So this is the way normal monocyte maturation pattern is there. So it is not exactly like a normal maturation. And you are having those blasts are also positive CD36 also. So 36-64 combination is more likely to be a monocytic lineage. So it is for a monocytic lineage, as I had shown in the previous table. So 64 is it's one of the FC gamma receptors. So it is its main thing of 64 is to bind to antibodies FC chain. So this is something like which many phagocytic cells will have, neutrophils will have those FC for gamma binding regions. So this is like that kind of a cell. CD36 is positive. 14 is like something like partially dim to, and 11C, which is a monocytic marker, is nicely homogeneously positive. So it is having 3 monocytic markers, 64, 11C, 2 out of 4 is already there. 45 is dim. So 36 is there, no 42B, no NG2 here. So you have CD3 is negative, 1A is negative, 2, 5 T cell markers are negative, 4 is little bit dim here. The 4 is not totally negative, it is a little bit dim here. And your anti-MPO is nearly negative. 11B is there. Anti-MPO, this can be sometimes be due to autofluorescence. So this could be, we cannot be very sure this much positivity is clearly positive, but more likely to be autofluorescence. Autofluorescence means many cells like neutrophils have flavins or normal chemical compounds inside them, which are part of our body. They also can fluoresce with certain laser lights, and they will send signals, and that will give you a false positive signal into the flow cytometer. This is not something which is there in IHC, but this is one of the issues which is there in when you are using a technique like flow cytometer. So 22-19 is negative. So immunophenotypic FISH again. So this is our summarizing it. It is like 45, 123 dim, 38 moderate, 86 dim to moderate, HLA-DR moderate, 15, 11B, 13 is variable, 33 and 36 and 64 are moderate, 11C is also moderate. So all of the features are that of acute monocytic leukemia. So this will go as an acute monocytic leukemia. Cytogenetics, though NG2 was negative, in this case, the cytogenetics is positive for KMT2A rearrangement. So we have had the second case. One case is an ALL, this case is an AML. So KMT2A rearrangement was positive in this. So this final diagnosis in such a case we will give, because patient is already in ALL, has been on therapy for 4 months and has developed an AML which is monocytic. So this would be what we would call as a therapy related AML. Therapy related AML. Therapy related AML is a comment to be given. It is AML by acute monocytic leukemia with MLL KMT2A rearrangement. So it is basically AML with KMT2A rearrangement, therapy related. So that's the way the current diagnosis is there. So there are various causes for therapy related AML. Like therapy related AML have a very poor prognosis. It's not a good thing, but it happens, and it could be due to direct induction of a fusion oncogene like topoisomerase 2 inhibitors, induction of genome instability by alkylating agents in radiotherapy, then selection of pre-existing cell clones, which can, previously something is there, abnormal microenvironment inducing a leukemogenic. So these are the 4 mechanisms by which are postulated for therapy related AML. So we don't have much of alkylating agent or radiotherapy as a part of AL, but we do have something called as topoisomerase 2 inhibitors, which are part of AL. So this is topoisomerase inhibitors are divided to those that inhibit type 1 and type 2. So in type 2, you have this etoposide, tenoposide, mitosandrone. These are all used very commonly for chemotherapy for various cancers, and you have anthracyclines. So in the anthracyclines, something called as a daunorubicin is used as a part of ALL induction. So this is known to cause this topoisomerase 2 inhibitor, which is very likely to cause a secondary AML. And most of those AMLs due to this topoisomerase 2 inhibitors are characteristically will have this MLL or KMT2A rearrangement. So this is like therapy related AML. So most of it will have this MLL rearrangement. So there are this is from a data of a large series. So this is for de novo AML. In therapy related AML, you will have either MDS related cytogenetic abnormalities, or you will have this T911, which is, if you see, is a huge chunk of this, or this MLL variant. So these two together will easily make up around 15% of your therapy related AML. Therapy related AMLs can also be your T821s, APMLs, inversion 16 also can be therapy related. Normal karyotype is there in 25% of therapy related AMLs. So this will fall most likely into this. The reason why I'm saying it is 911 is 911 is one of the most frequent MLL rearrangements in which NG2 is negative. So NG2 negative in this 911 rearrangement. I mean, this is little, what I'm saying is a little advanced, but just something to be in this case, which was peculiar. So that's why I'm highlighting it. So it is there. So this is just telling you how therapy related what are all there. So this 11q abnormality or KMT 11q23 is nothing but KMT2A. It's the location in the chromosome of KMT2A. So this is what our translocation 11q23 is, where the KMT2A gene is located. So these are all having those KMT2A rearrangements. That's why it is written translocations with KMT2A. It would be more proper to write it as translocation KMT2A than translocation 11q3. But it depends upon whether you're a molecular person or a cytogenetics person. The terminology is roughly the same. So alkylating agents, topoisomerase 2 inhibitors, transplant, all these can lead to this. So if you look at it, there are mutations also which can come as a part of therapy related genes. So this is the frequency in terms of that. So this was just a case unusual thing to highlight. So Nirmalya, you have any comments on this one?
Yes, sir. Actually, this is an extremely rare occurrence.
Rare. It's a rare occurrence. But
yes,
that I will have to emphasize. I totally agree.
Yes, and I mean, so early on in treatment is another very odd thing.
Usually, the MLL topoisomerase 2 inhibitors have a very short period between the treatment and onset of leukemia. Some of the shortest leukemias come into that category. Yeah.
That also actually, takes years. Actually, 2-3 years.
It's 2-3 years.
Yes. So the other thing is that was this patient KMT2A to start with ALL?
No, he was not KMT2A.
Right. I would think that I mean a missed KMT2A which has now evolved into AML to be a more likely diagnosis rather than a TA.
Yeah,
So
but that could be, but yeah, that is one of the thoughts which we can think in terms of.
Yes.
Yeah. Only thing is we didn't have the full workup of this patient, so all those possibilities still exist for this patient.
Right. And I mean, as you have highlighted that the outcome of therapy-related AML is not good at all. I mean, they need transplant. I mean, the transplant is mandatory to offer a curative treatment to TAML patients. But despite transplants, the outcomes are not more than 20 to 30%, as against the usual outcome of other AMLs, which are not therapy-related, which goes up to the range of 60 to 70%. And if you see the outcomes of ALL, they are the best in the class, and outcomes cross 90% in the current era. So TAML, of the three conditions that we mentioned, ALL, AML and TAML, TAML does the worst. That's it, sir. Thank you.
That's it.
Anything else? Any questions? If any
questions which I have missed or which I have taken up?
Monocytic AML more common in therapy-related AML, sir.
Monocytic AMLs are more common in MLL gene rearranged. So MLL gene rearranged, as I have shown, becomes a significant chunk of therapy-related AML. So that is the reason why monocytic leukemias come into that.
No further queries.
Nirmala, you have any other comments to make?
No, sir. No, sir. That's it, sir. Thank you.
Mani, you want to make any concluding comments?
Thank you. I think in these three cases, I have scratched the surface of acute leukemias. So that's all I can say. I don't know how much of it went above people's head and how much they could understand. Yeah.
I think it was an excellent talk, Mani. I really enjoyed listening to you. Students, do you have any question for Dr. Subramanian? Or if you don't have right now, you want to ask him, you can email him, or you can, he'll be happy to answer your queries. And if you're coming to Kharghar, you can always visit his lab in ACTRAC. He will take you for nice lunch and tea also.
Of course.
I think if there are no more questions, Ram, you have anything to say? Ru or Mohini, any comments you want to add?
No, sir, nothing from my end. And I think the students participated well, and they enjoyed sir's discussion as they could make out. And we also learned in the back end.
So, Mani, which are the common stains, cytochemical stains? Can you just tell briefly?
Yeah, cytochemical stains, I would say essential, most of it is given in DAISY. So one is MPO definitely, NSC second, third would be tall blue, pearls of course for ring sideroblasts. I'm not in terms of acute leukemia, but for in a hematopath lab which is going to deal with malignancies, pearls is important. Then these are the things which I can. PAS is useful mainly for erythroid. For MDS also PAS is useful. So that way, but generally for lymphoid, that dot block positivity one is not consistent. Even if you do it, it will not come in all the ALLs. But when it comes, it is helpful. But currently, the criteria don't tell us that you can make a diagnosis based on that. So in olden times, people used to make it based on that.
Anything about Sudan black, or which is your preference?
I prefer myeloperoxidase, despite the hazard for the benzidine. But yeah, my only argument is that the benzidine which we use for that is in milligrams, and that's not like, it's like a dose-related exposure to benzidine. It is there. If you want to be too careful, then it's better to avoid benzidine. But otherwise.
Do you think that the NGS will replace morphology and flow cytometry?
No, because the BCR-ABL itself tells you. If I just say somebody is BCR-ABL positive, do I know what disease the patient has? Because the treatments are different for different diseases. So it has to, the hematolymphoid is not going to get out of clinical morphology, say cytogenetics and things. Only the complexity is improving. So that is the way I would look at it. Maybe future people develop complicated algorithms which are able to tell by mutations what is the disease there. But I still feel that it's a long way out. At this point of time, no, I wouldn't.
So, this sample, sorry, sir, the samples to be sent regarding these testings, like starting from the.
So samples to be sent. See, if we have to, from cytogeneticist perspective, they always want a bone marrow. So if a bone marrow is done, it is basically for one diagnosis, and second is for cytogenetics. Because if bone marrow is not there, the cytogenetics have a lot of problem getting a metaphase. Even if bone marrow is there, in some of the diseases, metaphases are very difficult to get. So that we have to keep in mind. Otherwise, so cytogeneticists want the bone marrow in heparin. The reason is the moment you put it in EDTA, the cell cannot grow. They want the cell to be intact and able to grow right in, up to the time it reaches the lab. So heparin is preferred by cytogeneticists. Otherwise, for most of the molecular flow and other testing, an EDTA sample is more than sufficient. So even peripheral blood, provided the sample has tumor in it. If peripheral blood has very few blasts and you're sending it, then your molecular testing may not work in peripheral blood. But you have to send a sample. If peripheral blood has ample blasts, then molecular test will work from peripheral blood.
Thank you, sir. I think students, if you have any other queries to sir.
The students are intimidated by so many colors. So Mani, what do you suggest? How many color you should do for acute leukemia diagnosis? A lab should have what instrument? I mean, this is out of scope of this talk, but still, would you like to say 6 color, 8 color, or minimum? What do you say? Anything you want to suggest?
I think whatever I recommend, there will be somebody who will say with genuine reason that this is not correct. So
I
would rather say, if you're going for a minimum, I would prefer at least at a minimum 6. Doing it less than 6 is very difficult. Minimum 6, preferably at least 8 to 10 colors I would want. If you are just doing it only for diagnostic purposes. If you are doing for monitoring purposes, then I would ask for a 12 or a 13 color. If you're doing it, so that I would want, what's the aim of the lab also. 12 or 13 color as of today at a minimum.
Can you tell us a little bit about costing money? How much it costs a flow cytometric immunophenotyping and a cytogenetic case of acute leukemia, a B-cell ALL? How much it costs for flow and cytogenetics and genomics?
So costing means you are talking about a commercial cost?
Yes. We charge how much? We charge how much? Just for the students to know.
No, we see, we do subsidies, so our charges may not be reflecting a commercial cost.
Our private patient money.
Yeah, okay. Our private patients, then see, commercial cost flow will be anywhere 14 to 16,000. Then cytogenetics fish will be easily around maybe 6,000-7,000.
No, more than that.
More than that, maybe.
B-cell ALL panel will be more than. Nirmalya is gone?
Nirmalya is there.
No, I don't see him.
He's there, sir.
He's there.
Nirmalya, can't hear you.
I don't know.
Tell me.
Yeah.
Nirmalya, I want to ask you how much budget you give to the private patients for, let's say, a case of leukemia, a B-cell ALL in a child. So how much money he has to spend for acute leukemia private patient for flow, for cytogenetics, and for genomics?
So it's close to 1 lakh. So it's probably 80,000 in B category patients. If I'm not wrong, I mean, I might be a bit overestimating the cost, but I mean, that's what.
That's what? That's what I was coming to. It is almost a lakh. This is not counting your routine CBCs and coagulation and that thing which you do
Only
almost
the
daily.
diagnostic workups.
Diagnostic workup cost you a lakh. So,
Yes.
the costing has gone too high because of the new investigations, the multicolors, genomics. So I'm sure it has to come down sooner than later. But 20 years back when we did leukemias, when we didn't do MRDs, 30 years back, it used to be, the people used to take pride. The professor in AIMS Delhi and Dr. Banawali used to take pride. We can treat acute leukemia in less than 1 lakh rupee. No, that 1 lakh rupee 20 years back, maybe 5 lakh rupees now, or maybe 10 lakhs. But the lab was very minimal that time. Now the lab cost has really gone up, the testing. And how much is the treatment cost, Nirmalya?
Sir, for a private patient, depending on what risk we are treating, for a private patient with high risk BALL, the cost would be around 10 lakhs. That's the anticipated cost. For unforeseen complications, the cost, would go up.
So 18 months. This treatment goes for how many months for ALL, pediatric ALL?
2.5 years at the least.
2.5 years, a child will be treated for B-cell ALL, and you put the budget to the private patients as how much? 10 lakhs, 15 lakhs?
For high risk, 10 lakhs, sir.
Thank you.
Thanks.
That's all I think. Anybody else has any? Yeah, sorry. Yeah.
Query, sir, there is up to how much blast count in peripheral blood the flow cytometry can be done from the peripheral blood?
That will vary from center to center. So as well as the expertise available. But generally, I would assume that 5% blast should be easily be done in most centers. Below 5% will be difficult. We can go, like in my lab, we don't look at percentage. Any percentage, if it is there in circulation, even up to say 0.1%, we will pick it up. It just depends that, you require a certain number of events for you to confidently say there is a abnormal population. So say you take that if you want 100 events to be there to say an abnormal population. So if you are say 0.01% is your sample blast count, that is 0.01% will become one cell in something like 10,000. One cell in 10,000, and your say TLC is something like 1,000 cells. So per microliter. So 10 microliter sample will have 10,000 cells. So 10 microliter into 100, 1 ml sample should be sufficient for your picking up at to 0.01%. Below that, to go, you really require a higher count, either a higher count or a more amount of sample. 1 ml I am saying is theoretical. Preferably, practically 2 ml will be required because there is going to be around 50% cell loss in processing and all that. So at least 2 ml sample of 1,000 count should be there. But Nirmalya will tell you that we give them more sensitive than they really require. Nirmalya, is it?
Nirmalya is not, maybe again is muted him. But I think I agree with Mani. Means if you have somebody like Prashant or Sitaram, these guys in your lab, they will pick up 1 cell in a million. So 5% cells. We have many instances where bone marrow looks normal, peripheral blood looks normal, or CSF looks normal, and the flow shows blast. So one question is how many blast count. Second, more important is good blast from the bad blast. Mani, would you like to say that something about that, which you already mentioned? Some good blast versus bad blast. That's important to differentiate.
See, normal blasts will have a standard phenotype.
Yeah.
They are always, their protein expression is always very well tightly controlled. So they will always express the same way whichever patient you take, provided your panels and your processing are standardized. Panels machine processing is standardized. They will give you a constant expression. So that is our way of looking at the sample, whether it is normal or not. See, but it is like, say, for example, a good section histopathology, everybody will be able to make out what is what. But a poor section, Some people will be able to make out, some people will have difficulty. So that difference comes. So that standardization issue is always there. But if it is reasonably standardized, I think you can easily make out. One is standardization of processing. Other is your experience or confidence in interpreting. So like I said, 100 events for a novice or a beginner. But an expert who is very confident on his system of flow can even go down up to 20 events. So that means once you go down to 20 events, then your sensitivity will go below 0.01%.
I mean, just to add to what Mani said, if you have a morphology like post-induction bone marrow and you find 10% blasts or 15% blasts, they could be all good blasts like hematogones or good blasts. So morphology might not be always right. And sometimes you don't see blasts at all. And MRD will be picked up by sensitive flow. So the number of blasts on morphology can be deceptive. So morphology alone is important. You look at trilineage hematopoiesis, erythroid cells, myeloid, are they regenerating or not? Look at CBC, how the patient is behaving. But still, in a healthy looking marrow, the blasts can be either way. If they are more, they could be normal. We have seen cases of AML, post growth factors. Mani, would you like to say something about growth factors? What can they do?
Yeah, like especially in children in post-induction marrows, morphologically, sometimes you will have high percentage of blasts. So you say that in post-induction, the child is not doing well. He is saying, say, having 15% blast or 20% blast. So in olden days, if it was 15% blast, 20% blast, we used to consider that the child is not responding and it is a poor response. A small but a significant percentage of this are actually regenerating blasts. So when you do the immunophenotype, you are able to make out that they are normal myeloid blasts and they are not abnormal myeloid blasts. So if the immunophenotype is showing you normal myeloid blasts, there are multiple papers which have shown that these patients actually do very well and they don't relapse. And you should continue treatment instead of stopping treatment, especially in a scenario like Indian country where cost is a concern. And you give a 15% blast post-induction in an AML child, there is a very good temptation for the clinical person to say that, look, the child is not responding. Should I, if the patient is not having good financial strength, should I really continue the treatment or call it quits? So calling it quits in such patients is doing more harm to the patient. So in such circumstances, it really helps us one way or the other. So that is one thing which we'll have to do. So I mean, from the laboratory end, we will not know the clinical circumstances many times, but it is very important to keep these things in mind. The other area where we use this high sensitivity is we are a tertiary care center. So due to various exigencies and various necessary, patients do not come at presentation straight to us without treatment. So many times they would have had some stabilizing treatment and they come to us after that. So sometimes in BALL, especially, somebody has taken a transfusion and somebody inadvertently gave a steroid along with transfusion. The blast count goes low. And what was acute leukemia, we are not able to morphologically say with confidence one way or the other. In those circumstances, immunophenotypic or an MRD-like analysis becomes diagnostic.
Yeah, and another thing I just to add, the literature defines AML by 20% blasts as of today. It might change, other than, some molecular abnormalities. But in ALL, there's no definition like that of blast percentage.
So, the other problem is same slide, two observers can interpret significantly different in terms of percentages by morphology. In some cases, same slide, you give two people might get slightly different percentages, maybe sometimes significantly different percentages.
And even
whereas
if
immunophenotype, if you just give the FCS file to two people, if both of them know reasonably well how to interpret it, the inter-observer agreement is far higher.
Now, even intra, means if I see my bone marrow today and after a week, maybe there can be some variable, blast percentage. Can also happen. I might not agree with my, previous counts. I will ask who has seen it. Then somebody will say, "Sir, aap nahi dekha hai." Okay, maine nahi dekha hai. So.
It is not uncommon in ALLs to count blasts as lymphocytes. Many of my registrars who come to me first year, I have to correct them. They would say that there is 60% blast and 30% lymphocyte, whereas it's a full-blown acute leukemia. It's a similar high counts which has come. So in that circumstances, because if you look strictly based on morphology, you will be interpreting them as lymphocytes. I had actually highlighted that in this slide today.
And another thing, Mani, I think one word is context also.
Context.
Context is very important.
Dr. Borges always says that you have to interpret morphology in context. The problem is what happens when you're not aware of the context. Then it is your job to find out what is the context.
Context, yeah, you have to be aware. Context is extremely important, means, yeah, I think. Whether it's a clinical or the background cells, the neighboring cells. Actually, many times what I do when I report, I see 100 cells, first 100 cells, and then I ignore that count and I start counting again. Because many cells which I thought were monocytes in the beginning, when I've reached 70 or 80 cell count, I think that they are all myelocytes. So I've done wrong counts. So it's a good idea that, you count 100 cells and then ignore the count and then start counting the cells, because by that time you have made up your mind, which cells to be put in which category. Then chances of making mistake are much less. So first 100 cells count, but ignore the count, then count 200 cells.
The other thing, as a resident, we identify cells by what I would call as intuitive. This looks like a lymphocyte, so it is lymphocytes. Though we learn intuitively, we have to start asking us the question, what are the possibilities when we are asking, because that's a process of self-learning. I mean, no teacher can teach you. You have to ask yourself, understand, and move forward.
No, Dr. Rajiv Kumar can teach all of us. I've learned from him, all of us. Anyway, students, you have any...
I mean, teachers can teach certain level, but beyond that, it is a self-learn.
You have any questions, Sai? You want to ask something?
No, sir. Only, sir, I'll request you, like as we saw in today's case, sir, I was getting confused between that lymphoblast and a lymphocyte. What if a lymphocyte doesn't have a prominent nucleoli, and what is the easy way to identify apart from the context? Context, yes, I agree, sir.
Context is there. I think probably I didn't emphasize it more enough. There is no sure short way. That I will put as my first statement. There is no sure short way that you are going to say an individual cell is this or that. But there are reasonable ways to get a reasonable level of accuracy. So one of the things which I highlighted is the size comparison with red cell. See, normal lymphocytes are of two types. One is a small lymphocyte, which is what you should, in a smear, you should always hunt out the smallest lymphocyte and use that as your reference standard for your smear. This is what I do in my practice. So that way my confusion is reduced. I know this is the starting point and this is my scale, and based on this, I will interpret. Second is, don't interpret anything in thick area. You're going to have a lot of problems in this lymphocyte versus blast in thick area. Always go to a well red cell spread area in a smear. So these two things are very important in morphology. If I were to say it 100 times, I would still say it, because this is where your morphology begins. If you miss these two principles, then your morphology has ends up in a lot of confusion for you.
Thank you.
That means what I suggest when I have to do it, because like Mani said, Dr. Subramanian said, it's a problem. It can be a problem differentiating sometimes the normal lymphocytosis, CLL from ALL, the old FAB L1, which we used to call it many, many years back. Though if you look at chromatin, if you're a smart hematopathologist, but sometimes even then you have a problem. It can look similar. So what I suggest you are a young pathologist now, you take 10 cases of CLL and remove 10 cases of ALL, which have small cell morphology. Mix them and, and see where you can put them. even if you have 5 cases of CLL in your registry and 5 cases of ALL which have small blast-like cells, then look at the chromatin, look at the cytoplasm, size of the cells. They might not have a nucleoli, but you look at the chromatin, is it condensed, it is coarse, fine, it is uniform, homogeneous? What is the character of chromatin? Maybe you become wiser in picking up the blast from a lymphocyte, but there will be tricky situations. We have gone wrong. Even today, last week, I thought something as a PLL. It turned out to be ALL. So it's not that we are perfect. We make mistakes.
So what I said will work 80% of the times. That's the best accuracy I could get.
Ruchi, are you there?
Yes, sir, I'm there, sir.
Good. Actually, Ruchi had gone out, so I was
Thanks.
spending more time in questions and answers. Now Ruchi is back. I think we'll call it a day now.
Yeah.
Yes, I'll quickly announce the
Yeah, thank you.
Thank you, sir.
Thank you, everybody.